I will pass the podium over to Dr. Belamkonda to introduce Tony.
Thank you. Sorry, I'm having some trouble with my video camera. It looks like I'll keep working on it. But thank you, Dan. Thank you for allowing me to introduce Tony Giaimo, who is our wonderful second-year fellow. As you all know, Tony majored in biology at Fordham University, and then he decided to give back to the community and joined Teach for America as a core member and taught middle school in New Haven. If anybody has the opportunity of working with Tony, you will know that he is a very calm, composed, nothing phases me. Has a nothing phases me attitude, and I'm sure it has a lot to do with his experience as a middle school teacher for 2 years, and he worked here in New Haven school district. And then he went on to join our Yale primary care program, finished his residency, stayed on as a chief resident, and then did a year of hypertension fellowship, and is currently our second year fellow. He is passionate about hypertension and prevention in cardiovascular disease, and he's got a wonderful talk for us on ischemic MR.
Thank you very much for that introduction, Dr. Belamkonda. Can you guys hear me okay?
Yeah, you sound good, Tony.
Okay, thank you. So before I get started, I just want to take a moment to thank Dr. Belamkonda for her time and mentorship on this presentation. And on behalf of Yasin and Steffne, thank Dr. Miller and Dr. Velasquez for this opportunity. We certainly learned a great deal while putting this talk together. So the title of our talk is Ischemic Mitral Regurgitation, a marker for LV function or a target for intervention. Specifically, we'll be presenting three sides to the debate regarding the management of ischemic MR, because the best therapy for chronic secondary mitral regurgitation is much less clear than it is for chronic primary MR. I will advocate for the fact that secondary MR is a marker of LV function that should primarily be managed with medical therapy focused on the ventricle. Yasin will advocate for the role of transcatheter edge-to-edge repair, and Steffne will discuss the data behind surgical management of mitral valve disease. We won't have time to get into various debates over imaging the valve and or quantifying mitral regurgitation. We're also accepting up front that patients should be revascularized. I have no conflicts of interest. These are my learning objectives. I'm going to start by differentiating secondary mitral regurgitation from primary. I'll go on to review the pathology of secondary MR as a problem with the ventricle, and in describing the prevalence, tell you about a patient and how ischemic MR affects outcomes, and then finally go on to discuss the evidence for medical management that exists in the guidelines. So I'll start just by briefly reviewing the Carpentier classification of mitral leaflet mobility in MR. As you know, type 1 is an isolated annular dilation with normal leaflets, but poor coaptation. Type 2 refers to excessive leaflet mobility above the annular plane, such as in mitral valve leaflet flail. Type 3A, the leaflets and or the subvalvular apparatus themselves are diseased, causing restricted motion in both systole and diastole, as occurs in rheumatic valve disease. And then finally, 3B is what we'll spend the majority of our time talking about today, where the ventricle is dilated or hypokinetic. So secondary MR is Carpentier type 3B, and refers to the fact that the leaflets and subvalvular apparatus themselves are accepted as not diseased. You can have ischemic or non-ischemic MR, and I'm going to go through the pathophysiology for both. This sketch here shows more of an ischemic MR. As you can see here on the right, in the infarcted ventricle, the effect of a hypokinetic wall pictured in black, displacing the papillary muscle, causing leaflet tethering that restricts closure of the valve. And this can occur independent of LV dilation. However, LV dilation is the more common pathophysiology behind secondary MR. And after weeks of reviewing innumerable papers on this topic, this graphic by Mullins explaining the contributors to secondary MR due to a dilated cardiomyopathy is one of our favorites. So in the normal myocardium on the left, we see that mitral valve closure is a result of a balancing of forces produced by LV contraction and tethering forces along the mitral subvalvular apparatus. On the right, we see that mitral regurgitation occurs in heart failure, represents a loss of balance of those forces. Remodeling of the LV due to whatever the underlying myopathy is leads to displacement of the papillary muscles and apical tethering of the leaflets. This results in restricted motion of the leaflets in systole and hence impaired coarctation. Reduced closing forces due to a loss in contractility of the ventricle also contributes to leaflet malcoaptation. And then dyssynchrony of the LV that can occur in a dilated cardiomyopathy associated with the wide left bundle branch block contributes to both increased tethering force and decreased closing force. And I'll discuss the data behind CRT as a remedy for that. So I'll bring your attention to the bottom of the graphic. Here you see an increase in fibrosis within the leaflet of the heart failure mitral valve. There's some evolving data to support the possibility that the mitral valve leaflet themselves become abnormal as a result of the MR. And in regards to this, I'll only point out that ARBs are thought to arrest these changes. So I think this pathophysiology supports secondary MR as a ventricular problem, and I'll go on to talk about why I think, especially at first, our efforts should be focused on treating the ventricle. Ischemic mitral regurgitation is a prevalent disease in the acute phase. Prior to discharge after acute MI, about 38% of patients have some degree of ischemic MR. And chronically, some 8 months post PCI, the data shows that about 28% of patients continue to have some degree of ischemic mitral regurgitation. And so it's not infrequent that we admit a case such as this one to the CCU. This is a 70-year-old gentleman who presented with acute decompensated heart failure that we cared for. He described a week of gradually worsening dyspnea and a day of Cheyne-Stokes breathing. And this occurred in the context of having had an anterior wall STEMI about 3 months prior, for which he underwent drug-eluting stent to the prox LAD, as well as requiring stent to the left circumflex at an outside hospital. He was left with a reduced ejection fraction and moderate mitral regurgitation. On exam, his blood pressure was 96/56 with a pulse of 85, and he was hypoxic, requiring supplemental oxygen. And then on exam, generally can describe him as warm and wet. His studies were significant for a normal troponin and unchanged ECG, but an elevated BNP. And his transthoracic echo showed the following. So in the peristernal long axis view, we can see a dilated left atrium, along with likely severe MR that's associated with a tethered, but otherwise normal pairing posterior leaflet. And we can see there's also some AI there. In the 4-chamber view, we can appreciate hypokinetic, severely dilated left ventricle with really torrential central and posteriorly directed MR. And we can probably better see the tethering of the posterior leaflet here. So with this presentation and his history, he did undergo left heart cath that showed patent stents and no new obstructive disease. We had to place a Swan-Ganz catheter and start inotropes in order to diurese and relieve his symptoms. This outcome is not too surprising when you consider that this data compiled by Grigioni and Jack in 2005 shows that patients with ischemic MR after an MI have a much greater incidence of heart failure, and that's what's pictured here. And then furthermore, they have a much lower event-free survival. So on the y-axis here, we have percentage of survival, and you see that patients left with ischemic MR after the MI have much worse outcomes. And finally, the severity of MR after an MI correlates with worsening survival. So you see here that MR is stratified based on effective regurgitant orifice area. We have 3 sort of points of differentiation here. and patients with ischemic MR with an EROA above 20 do significantly worse. So the immediate question from the CCU team was whether this gentleman should be referred for intervention on his mitral valve. So at the same time that the Advanced Heart Failure Service was asked to assume his care, the structural and CT surgery teams were consulted regarding intervention to the mitral valve. So, but I'd like you to first take a look at this patient's admission medication list. It's the same medications at the same doses that he was discharged from the hospital with after his MI 3 months ago. He's on a low dose of a suboptimal beta blocker and a low dose of lisinopril. And I'm obliged to point out that he's not even on a high intensity statin, but that's for another talk. So I point these out because this gentleman has not yet had a chance at GDMT titrated to target doses. Unfortunately, this is how many patients like him come to attention. And for those of you that had a chance to attend the Yale CME talk on mitral valve interventions last week, you know that one of the important takeaways was early referral, so that we can try to optimize these patients before they present, like our gentleman, in cardiogenic shock. I've yet to show you his ECG, so here it is, showing sinus rhythm with ventricular trigeminy, along with a wide QRS of about 140, 150 milliseconds with a left bundle branch block morphology. So how should we proceed with managing our patient? Let's take a look at the guidelines. So about a month and a half ago, of course, in the middle of the prep for our talk, the 2020 ACC AHA valve guidelines were released. Thankfully, I only had to adjust a few slides, but the updated management algorithm continues to prioritize first and foremost guideline-directed medical therapy. So I'll take this opportunity to point out to you that despite what my co-fellows tell you, the evidence for interventional management of secondary MR is still relatively weak. Mitral valve surgery, especially in the absence of the need for revascularization, has a weak 2B recommendation. Transcatheter edge-to-edge repair, newly included in these guidelines on the back of the COAPT data, has a 2A indication for a narrow population of patients that are non-responders to currently available medical therapy. So the only class 1 indication with level of evidence A for the treatment of severe mitral regurgitation is medical therapy. So I'll pause here to tell you that we do not have randomized controlled data to show that currently recommended GDMT, such as beta blockers, RAS blockade, etc., improves mortality or heart failure outcomes specifically in patients with secondary mitral regurgitation. And in his paper here, Dr. Velasquez refers to this clinical equipoise, and the fact that it's unlikely we'll ever be able to study these in a randomized fashion, due to the need for background heart failure therapy. But these therapies have a class 1 indication because they improve the LV and reduce afterload, targeting the underlying myopathy of the ventricle. Because as I previously described, this is primarily a ventricular problem. We do have mechanistic studies assessing their effect on MR, and I'll share some of that data with you today. But just to note that new therapies should be assessed for their effect on secondary MR. And so this is a screenshot to the familiar recommendation table from the guidelines. GDMT specifically, described as ACE inhibitor, ARBs, beta blockers, aldosterone antagonists, and now also sacubitril, valsartan. Biventricular pacing, as indicated, as cardiac resynchronization therapy, also carries a class 1 indication. New to these guidelines and also carrying a class 1 indication is a recommendation for CHF patients with chronic severe MR to have their GDMT managed by a heart failure specialist to ensure it's optimized. This recommendation, as I understand it, comes from the design and implementation of the medical arm in COAPT. And so this is, what guided our next steps, and both structural and CT surgery agreed that an intervention for our patient was not the best next thing to do. The next step was to consult electrophysiology. And we did so because CRT improves ischemic MR and its outcomes in select patients. In this study by Van Bommel's group, we can see significant improvement in markers of MR after CRT, including here in panel B, an improvement in EROA. They followed patients for 5 years and showed a survival benefit between those that had improvement in MR versus those that did not. CRT reduces secondary MR by synchronizing and improving LV regional and global contraction, often inducing significant reverse remodeling that lessens the tethering forces and improves those closing forces that I described earlier. For some patients, it's dramatic. This provides immediate improvement in MR. I don't have time to show you those images, but they're impressive. In others, it takes time to reap the benefits of reverse remodeling. However, as you see here in the subset of patients, MR does not improve. I'll just note that CRT is currently not indicated solely to treat secondary MR. Like our patient, you must otherwise meet criteria for CRT. So with this data, a CRT-D device was placed by EP during the hospitalization. So with his symptoms relieved by diuretics and inotropes and his LV dysynchrony treated with CRT, the next step is to introduce and uptitrate guideline-directed medical therapy. And as my slide title advocates here, the focus should be on the heart failure. I'll review some of the data regarding the effects of each class of drugs. So in this study, patients with a mean ejection fraction of 24% and secondary MR were randomized to either carvedilol or placebo with a background therapy of ACE inhibitor or ARB. After 6 months of CoReg uptitrated to a dose of 44 milligrams daily, mean MR stroke volume and mean forward aortic stroke volume both improved. And the authors concluded that treatment with carvedilol induces significant reduction in MR while increasing LVEF. And this graph shows change in MR volume from 6 months to baseline with carvedilol on top and the control patients on the bottom. As you can tell from this chart and the fact that the placebo group had no background beta blocker therapy, this study was done in the late 90s. And this study here showed that RAS blockers and nitrates can reverse secondary MR. This was a study of the effects of high-dose lisinopril isosorbide dinitrate on patients with severe MR. And at 1 year of follow-up, New York Heart Association class and heart failure hospitalizations decreased while ejection fraction went up. And this table shows that at 12 months, 2 subgroups were identified. MR responders, as in those whose MR decreased to 0 or mild, and MR non-responders, those who remained with moderate or severe MR. And although these subgroups had similar demographics, symptoms, functional status, clinical findings, and ejection fraction, the MR responders, as you can see here, had a significantly smaller initial left ventricular and diastolic diameter when compared with non-responders. And so as the importance of secondary MR has become increasingly appreciated, newer therapies such as sacubitril valsartan are being assessed for efficacy. So while Paradigm showed that an ARNI can reduce mortality in heart failure hospitalizations in patients with HFrEF, no data regarding the prevalence or change in MR was reported. But this group from Korea did a prospective, multi-center, double-blinded, randomized controlled trial evaluating whether sacubitril valsartan is superior to valsartan alone in improving secondary MR. And the trial included HFrEF patients with class 2 to 3 heart failure and an EF from 25 to 50. Generally, these were not candidates for CRT, and they were included based on these functional MR criteria. Their functional endpoint was a change in EROA at 12 months, and patients were randomized and stratified according to ischemic versus non-ischemic functional MR. So this attention to treat analysis showed that here a significant improvement in the primary endpoint of EROA, and amongst the secondary endpoints, regurgitant volume and end diastolic volume index both improved. This bar graph summarizes the result showing that in the ARNI group, no patients had worsening of their MR, and a greater percentage, pictured here in white in the bar, had improvement. But again, this is a mechanistic study and not an outcomes trial. So in follow-up to our patient, he was weaned off of inotropes, and carvedilol and sacubitril valsartan were introduced. And these, along with spironolactone, were optimized over the ensuing months. 6 months later, as an outpatient, this is his echo, showing a significant reduction in his ejection, in his mitral regurgitation. And you can appreciate that here in the 4-chamber view, showing really mild MR. And he's not been rehospitalized in 2 years. So in summary, as we transition to Yasin's part of the talk, I'll leave you with the question: is intervention on the mitral valve really the treatment for a disease that's caused by a ventricular problem? Ischemic MR is prevalent, carries a poor prognosis, but it's a consequence of the underlying myopathy and not primarily a valvular problem, and should be managed medically, especially at first. And transcatheter edge-to-edge repair carries a 2A indication for a narrow population of non-responders with persistent severe MR. And with that, I will pass it over to Yasin. Thank you very much.
So good morning, everyone. It's my pleasure to introduce Yasin, who's going to be presenting some data on the transcatheter edge-to-edge repair. Yasin went to medical school at New York Presbyterian Weill Cornell and Qatar, and then did his residency also in New York City at Cornell, and then is here now with us as a cardiology fellow. And we're very lucky to have him staying on as an interventional cardiology fellow here in about a year and a half. So without further ado, he's going to present the data on transcatheter edge-to-edge repair for secondary MR.
Thank you, Dr. Capel, and thank you all for being here. Can everyone hear me okay?
Yes.
Okay, perfect. So I'm going to be talking about the percutaneous therapies in ischemic MR. I have no conflicts of interest for this talk. And my outline is going to be as follows. So, Tony did a great job telling us about GDMT and how it's the primary and class 1 indication for these patients, but we need to look at how well these patients actually do being on GDMT. Then I'm going to talk about the evidence for transcatheter edge-to-edge repair or mitral clip, and these I may be using interchangeably. And finally, really patient selection is key, and I'm going to be talking about disproportionate or proportionate MR. So just a little bit of a review. After an ischemic event, we have alveolar remodeling, which causes displacement of the papillary muscles, which in turn leads to malcoaptation. And this imbalance between the tethering and the closing forces leads to the MR. And then when we get to the stage where there is MR, the process becomes self-perpetuating, resulting in worsening MR, resulting in LV dilation. The LV dilation then dilates the mitral annulus and worsens MR. And our therapeutics are aimed at kind of halting this process. So there's an idea that perhaps MR is just a byproduct of a bad LV, and I think that's what Tony was presenting, and doesn't really pretend to greater risk and worse prognosis. So this prospective observational study of over 500 patients, severe functional MR, had a lower survival even after adjusting for clinical confounders. And this patient population was on, pretty adequate GDMT. 96% of them were on full dose RAS inhibition, 71% of them were on beta blockers, and 40% on MRAs. So, in this patient cohort on good GDMT, severe MR still has a severe adverse prognostic impact. And in this analysis of the STITCH trial, and obviously GDMT has changed substantially in the last decade, but in this analysis of the medication arm, which had 599 patients, mortality was strongly related to MR, and this includes both mild and moderate MR. So this kind of highlights the point that regardless of your medication, regardless of the medical treatment, if you have severe or moderate to severe MR, you have a worse prognosis. In the next part of my talk, I'm going to start focusing on the two major mitral clip trials, MITRA-FR and COAPT, and I'm going to really be focusing on the intervention arms of these two trials. But it's really important to highlight that, you know, these were pretty recent trials with agreed upon good GDMT, especially in the COAPT trial. But if you look at the GDMT arm, there's cardiac death about close to 1%, close to 20% in both trial arms, in both trials in the medication arm, and the hospitalization is nearly half the patients at 1 year. So transcatheter edge-to-edge repair basically establishes vertical coaptation by drawing the leaflets together. This is done on a beating heart, so patients are not on bypass, they don't require pacing, and it's done under transcatheter, transesophageal echo, so there's real-time assessment of the mitral valve function. So COAPT and MITRA-FR both assess the utility of mitral clip in addition to GDMT compared to GDMT alone in patients with heart failure and secondary MR. And the trials both had very strikingly different results. And that's what we're going to focus on the next part of the presentation, why they were so different. So going over the trial design, both trials were multi-center randomized open label trials, and from a bird's eye view, assessed a very similar patient population. The COAPT trial almost enrolled double the number of patients compared to MITRA-FR, and the trials had somewhat different definitions of MR severity based on, you know, ESC guidelines in the MITRA-FR trial and AHA guidelines in the COAPT trial. Both trials had kind of similar inclusion for New York Heart Association class, similar, although not exactly the same, EF inclusion criteria. And I just wanted to highlight some of the exclusion criteria. So in the COAPT arm, anyone with a left ventricular end systolic diameter greater than 70 millimeters was excluded, and anyone with high PASP pressure or pulmonary systolic pressures higher than 70 was also excluded. There was no mention of exclusion of these patients in the MITRA-FR arm. So the primary efficacy endpoints in both trials were also a little bit different. So COAPT looked at all hospitalizations for heart failure within 24 months, although, you know, the trial was powered for analysis of the 10 secondary endpoints. And MITRA-FR looked at the composite of death from any cause or unplanned hospitalizations for heart failure at 12 months. I'm going to go over the results of the trials. Obviously, we all know they're very different. And then after that, go back and look at the patient populations in a little more detail. With regards to heart failure hospitalizations, the results from COAPT trial presented on the left of the slide show a significant reduction in heart failure hospitalizations at 24 months, with about 35% in the treatment arm compared to 57% in the medication arm. And the curves show this difference pretty early on, around the 0 to 3 month range. On the other hand, the MITRA-FR showed no differences in hospitalizations for heart failure between the device arm and the medical arm. And this slide shows a significant difference between the two trials with regards to heart failure hospitalizations. And the same is true with regards to all-cause mortality. The results from COAPT, shown here on the left of the slide, showed a significant reduction in all-cause mortality at 24 months, with a hazard ratio of 0.62 favoring the device arm. This reduction in mortality was seen at 12 months with a hazard ratio of 0.79, again favoring the device arm. And when we look at the MITRA-FR results, we see really no difference between the device arm or the medical treatment arm. These are kind of the main 2 points or takeaways from the results of the slide. So with regards to all-cause mortality, with regards to heart failure hospitalizations, again, a seemingly similar population, seemingly similar question, very, very different results. So we're going to go over the baseline characteristics of the 2 patient populations. So I'd like to point out the similarities in the age group here, kind of similar percentages of patients with ischemic cardiomyopathy, and a similar distribution of the New York Heart Association class. So the majority of patients in both trials had New York Heart Association 2 or 3. The bottom of the table represents the baseline medical therapy, which seems to be comparable between the two groups, with higher rates of RAS inhibition in the MITRA FR arm and higher rate of beta blocker use in the COAPT arm. However, there's a main difference here, which is that before enrollment in the COAPT arm, the adequacy of medical therapy was reviewed by a central committee consisting of heart failure specialists. So really, these patients had, although we don't really know the doses exactly, but had maximal medical therapy as judged by a heart failure specialist, and that wasn't really true for the MITRA FR arm. I think this is very key. This is key to understanding why the results were so different. It represents the baseline echocardiographic parameters between the two trials. The MITRA FR population generally had a larger LV and diastolic volume index and generally smaller effective regurgitant orifice area. Over half the patients in MITRA FR had an EROA of less than 0.3 centimeters squared compared to less than a fifth in the COAPT population. And almost half of the COAPT population had an EROA of greater than 0.4%. This to me represents two substantially different patient populations based on their echocardiographic parameters. And then finally, the procedural complications and the procedural differences between the two arms. So COAPT was done in North America. By the time this trial was happening, it was already 7 years after approval of MITRA FR, thanks to the Everest trial, and operators generally had better experience than in France at the time of this trial. And this shows a smaller percentage of complications and device implant failures, and a higher percentage of successfully lowering mitral regurgitation at 12 months to less than 2 in the COAPT arm, of about 95% success versus 80% in the MITRA FR arm. So far, since the publication of both of these trials, there's been a lot of debate. Why have there been such stark differences? And some possible reasons include, potentially that the COAPT GDMT arm was led by heart failure specialists that resulted in better results, or it could have been that the procedural results were better in COAPT, and that was the reason for the better results. But I think the main point here, and the point I'm going to highlight next, is that it really was about patient selection and the population that was looked at in the two trials. So this is really key. This observation of the difference in the two trials led to a proposed new framework for thinking about functional MR, proposed by Paul Grayburn and his colleagues. And the main concept behind this is that the functional MR first is very heterogeneous, and that the EROA is very dependent on the left ventricular and diastolic volume. So focusing on this figure, obviously the EROAs here on the y-axis, the left ventricular and diastolic volume on the x-axis, and there were some factors that were taken into account. So this was based on an LVEF of 30% and a regurgitant fraction of 50%, which everyone agrees is severe. So that's half of your stroke volume going back into the left atrium. So these were fixed parameters. And then what they did to propose this model was, as you move along the black line, as you're increasing your left ventricular and diastolic volume, to be able to get a regurgitant fraction of about 50%, your EROA had to increase. So if you're on this black line, then your mitral regurgitation is proportionate to the degree of LV dilation. And you can have severe MR with an EROA of 0.2 if your left ventricular and diastolic volume was about 150. The gray zone here takes into account the degree of uncertainty with EROA measurements by echo and the patient hemodynamics, which can kind of move things around this gray zone. If you're in this green area, then you have mild to moderate MR, and your mitral disease is really not that significant. The main kind of different population is this population here in pink, where you have severe and disproportionate MR. So it's out of proportion to the dilation of your left ventricle. So in this proposed model, for example, an EROA of 0.35 or 35 millimeters can be explained to be proportionate to your LV disease by an LV end diastolic volume of about 300. But it cannot be explained by an LV end diastolic volume of about 150 or 200. It's out of proportion to that. The main point of the slide really is that the EROA is affected by left ventricular end diastolic volume, and a large EROA with a smaller LV is consistent with disproportionate MR. So this is really describing two different patient populations. Those whose MR is entirely explained by global distortions in mitral valve function produced by marked enlargement of the LV cavity. That's one population. The second is those whose disease process within the LV, again, we're talking about functional MR here, right? So the disease process within the LV acts to disproportionately injure segments of the ventricle that then that are important in supporting the normal mitral valve coaptation. And hence their LV is not really dilated, but there are areas that are functioning a little bit less, affecting the mitral valve. And that's why their MR is disproportionate to the general dilation of the LV. So if we go with this framework, then we need to focus on what the problem is, right? So patient management should be guided by whether or not the MR is proportionate or disproportionate to the level of LV remodeling and dilation. So if it's related to the LV, then your management should be directed at LV remodeling, and intervention on the mitral valve is really not going to be that helpful. The opposite is true. If your MR is disproportionate to the LV dilation, then we really should be focusing on fixing the problem with interventions. If, again, this patient is not benefiting from GDMT alone. And then when we look at, using, again, this framework where MITRA-FR and COAPT lie, the COAPT patient population lies within this disproportionately severe MR. So their mitral regurgitation can't really only be explained by LV end diastolic volume. It is due to dysfunction in the LV, but that dysfunction may be in an area that makes their MR disproportionate, versus the MITRA-FR arm, is close to the non-severe MR, but if we want to argue that it's proportionately severe MR, meaning that their MR could be explained by solely LV problem, LV dilation, and we need to focus on the remodeling aspect and fixing the LV really for the MITRA-FR population. So this concept was further explored in this secondary analysis of COAPT. Again, there's limitation to this because it's secondary analysis, very small number of patients. But what they basically tried to do is they took the COAPT patient population and they dichotomized it into two groups based on the left ventricular end diastolic volume index and the regurgitant orifice area. They used the LV-EDV mean of 96, which was the median, of 96, which was the median in COAPT. And they used the EROA of 30, which was the mean in the MITRA-FR group. So group one, which is MITRA-FR-like, again, these are all COAPT patients, had an EROA of less than 0.3, a left ventricular end diastolic volume index of greater than 96. So a smaller orifice area, more dilated LV. Group two had a larger orifice area and not a significant LV dilation. And the outcome that they looked at was composite of heart failure hospitalizations and all-cause mortality. They also looked at other outcomes, non-hard outcomes like 6-minute walk test, quality of life improvements. But I'm going to be focusing on the main outcomes here. So group one, again, represented in A and D, is the MITRA-FR-like group. This is a group with a large LV, a smaller EROA, again, within the COAPT population. Group figure B, B and E here represent the typical COAPT population with a smaller LV, large orifice area. And HFH is heart failure hospitalizations, ACM is all-cause mortality. And we notice here that in the MITRA-FR-like group, there's really no benefit with regards to the composite of heart failure hospitalizations or all-cause mortality or all-cause mortality alone. But we do see that there's a benefit to mitral clipping in addition to GADMT in both of these outcomes. So going back to the patient Tony presented, it's not that this patient needed an intervention. The patient benefited from medical therapy. The patient had a dilated LV and likely would not have benefited from mitral clip. But that doesn't mean that every patient with mitral regurgitation will not benefit. When used in the correct patient, mitral clip has a substantial clinical benefit with a number needed to treat of just 5 to reduce all-cause mortality. So the point of this slide obviously is not to compare medications of HFrEF, which can obviously be used in a very heterogeneous population, to this very specific population of the COAPT trial, but it is to show that in patients who are on GDMT that fit the disproportionate MR criteria, if you do mitral clipping, your number needed to treat for patients to benefit is very, very small. And under the 2020 valve guidelines that Tony pointed out, patients within the COAPT substrate should be considered for mitral clip if symptomatic on GDMT. So in conclusion, functional MR is a heterogeneous disease. The AROA LV-EDV relationship is important to understand the proportionality of the MR, and mitral clip is an effective therapeutic option in patients with disproportionate MR. Thank you very much.
All right. Good morning, everyone. It is my pleasure to introduce Dr. Steffne Kunnirickal. Steffne is a second-year fellow in the general cardiology program at Yale. She completed her medical school in the combined bachelor MD program at Drexel University. She went on to match at Yale for internal medicine, stayed on as a fellow, and we will be lucky to have her as an interventional cardiology fellow here at Yale. Steffne will be discussing the role of surgery in ischemic MR.
Thank you, Dr. Asif, for the introduction. Good morning, everyone. Today, I'll be discussing the role of surgical interventions in ischemic MR. I have no disclosures. So this is a clinical scenario that we routinely encounter in our practice. You have a 65-year-old man with past medical history of inferior myocardial infarction with the EF of 50%, hypertension, hyperlipidemia, diabetes, who presents with exertional chest pain and shortness of breath. The Transthoracic Echo reveals an EF of 45%, inferior and inferior lateral akinesis, and moderate to severe ischemic mitral regurgitation. He undergoes a diagnostic angiogram that reveals obstructive 3-vessel coronary artery disease. So how would you treat this patient? This is certainly not a patient whom we would consider PCI and medical therapy alone. And he's definitely not a high-risk surgical candidate to be considered for mitral clip. So given his history of diabetes and multi-vessel coronary artery disease, this is the kind of patient you would refer for a bypass surgery. So the objective of my talk today is to address 2 primary questions that cardiologists and cardiac surgeons frequently encounter when treating patients with ischemic MR. The first question is revascularization alone sufficient to address ischemic MR? Or should we advocate for this patient to undergo mitral valve surgery in addition to a 3-vessel Cabbage? And if we choose to intervene on the mitral valve, should we repair or replace it? So Tony has illustrated that the presence of mitral regurgitation after a myocardial infarction is associated with poor outcomes. While optimal medical therapy alone may improve ischemic MR, as Yasin has pointed out, there is a select patient population with disproportionate MR who will benefit from mitral valve interventions. And it is to be noted that mitral clip was only studied in patients who were not candidates for surgery. And we're all familiar with this dictum, MR begets MR. And the role of surgical intervention is to halt this vicious cycle of LV overload by restoring the mitral valve competence and initiating sustained LV reverse remodeling. So multiple observational studies have consistently shown that revascularization with or without concomitant mitral valve surgery is better than medical therapy alone for ischemic MR. So this is a study out of Duke led by Tricon colleagues that looked at the relationship between various treatment strategies and survival amongst a cohort of patients with ischemic MR. They found that revascularization with either PCI or Cabbage in mitral valve surgery was associated with improved survival as compared to medical therapy alone. Similarly, an updated analysis by Castleberry and colleagues, which included almost 5,000 patients and looked at longer-term outcomes, demonstrated the superiority of Cabbage over medical therapy in this population. This study also showed that Cabbage in mitral valve surgery was better than PCI in these patients. However, an important question still remains, and that is whether revascularization alone is sufficient, or should we add a concurrent mitral valve surgery? So observational studies provide very conflicting evidence on whether the mitral valve surgery adds any better outcomes. While these two studies show that the mitral valve surgery, in addition to Cabbage, was not superior to Cabbage, a sub-study of the STITCH trial demonstrated better outcomes when mitral valve surgery was added to Cabbage in patients with moderate and severe MR and LV dysfunction. So to address this question, I would like to stratify MR based on the severity. And when you look at the subgroup of patients with severe ischemic mitral regurgitation, there's no randomized control trial to date evaluating whether revascularization alone or concomitant mitral valve surgery provides better outcomes. And this is due to lack of clinical equipoise. In our current practice, when a patient with severe ischemic MR goes for surgery, the mitral valve is usually intervened on. And furthermore, when you look at observational studies that attempted to answer this question, the proportion of patients with severe MR undergoing surgery alone was on average 2 to 4%. So a definite conclusion cannot be reached based on these studies. On the other hand, the indication for mitral valve surgery in patients, in addition to Cabbage, in patients with moderate ischemic MR is an area of huge debate. Cabbage alone may improve LV function and reduce ischemic MR in select patients. However, there's an early persistent MR rate of 40 to 60% after isolated Cabbage. So I'd like to highlight 3 important randomized controlled trials that evaluated the benefit of Cabbage alone and Cabbage plus mitral valve surgery in moderate ischemic MR. The first study here included patients with the LV end diastolic dimension of 59 millimeter and average LVEF of 42%. All patients in this trial had prior MI, and they demonstrated significant improvement in its primary endpoints of NYHA class, LV dimensions, and EF in the combined surgery group. Similarly, the RHYME trial enrolled patients with baseline characteristics that were pretty similar to the first trial. And they also demonstrated improvement in the primary endpoint of peak oxygen consumption and secondary endpoints of LV end systolic volume index, MR grade, and NYHA class in the combined surgery group. The third study, the CTS network trial, enrolled patients with a smaller LV end systolic volume index compared to the other trials. And this study did not demonstrate a significant difference in LV end systolic volume index or heart failure admissions. However, they did note some improved exercise capacity in patients who underwent the combined surgery. So what are the benefits of adding mitral valve repair to the Cabbage in patients with moderate ischemic MR? Lower incidence of persistent MR. All these 3 trials demonstrated that Cabbage alone had significantly higher incidence of persistent moderate to severe MR at 1 to 2 years compared to the repair group. The CTS network trial had lower incidence of persistent MR compared to the other trials. This could be explained by the fact that the patients enrolled in the CTS network trial had MR secondary to reversible ischemia rather than scar, since they had fewer patients with prior infarcts. And in the CTS network trial, the higher incidence of MR in the Cabbage alone group did not translate to any hard clinical endpoints in the 1 to 2 year follow-up. However, we need longer-term outcomes data to definitively say that this degree of persistent MR after just Cabbage has no clinical impact. And all these 3 trials demonstrated improved NYHA class or quality of life in the combined surgery group. And note that these trials were not powered to detect mortality benefit. One of the interesting findings from the CTS network trial was the effect of revascularization on ischemic mitral regurgitation. So in order to study this, they analyzed the changes in wall motion score index in patients with and without persistent MR. So in patients who had no persistent MR after revascularization, they found that they had a greater degree of wall motion score improvement in the wall motion score index compared to those with persistent MR. This could drastically improve surgical decision-making, as viability testing with MRI or PET scans can be used to identify patients who will improve with revascularization alone. And those with non-viable scar that are unlikely to improve with revascularization alone can then be carefully selected for concomitant mitral valve surgery. However, we need larger trials that with viability testing to demonstrate, to confirm this finding. So to summarize my first section, revascularization alone is associated with higher incidence of persistent MR, and Cabbage alone may be sufficient for select patients with moderate ischemic MR and viable myocardium, but a concomitant mitral valve surgery may be needed in patients who had prior MIs and scar. So these trials demonstrate the importance of patient evaluation selection rather than invalidating mitral valve surgery for moderate ischemic MR. So moving on to the second question of repair versus replacement for ischemic MR. Traditionally, repair has been associated with lower perioperative mortality, but replacement provides a more durable result. Although repair is generally favored in primary degenerative MR group, up until recently, there was no randomized controlled trial comparing repair versus replacement for ischemic MR. The CTS network conducted a randomized controlled trial to evaluate the relative benefit of repair versus replacement in patients with severe ischemic MR. And they included a patient population with a mean EF of 40%. About 75% of these patients had prior infarct, and 75% underwent concurrent Cabbage. All these patients were on GDMT and had CRT, and those who underwent replacement had complete preservation of the subvalvular apparatus. And those in the repair group had a downsized rigid or semi-rigid annuloplasty ring. Although both groups demonstrate improvement in the primary endpoint of LV end systolic volume index, there was no significant difference between the two groups at 1 or 2 years. And they also noted no difference in the secondary endpoints of mortality and major adverse cardiac or cerebrovascular events between the two groups. However, at 2-year follow-up, the repair group had higher incidence of recurrent MR compared to the replacement group. And this translated to more heart failure-related adverse events and cardiovascular admissions. Although both groups demonstrated an improvement in heart failure symptoms compared to their baseline, the replacement group had greater reduction in symptoms compared to the repair group. A subgroup analysis conducted and demonstrated that patients who underwent mitral valve repair with no recurrent MR had a significantly higher degree of reverse remodeling compared to the replacement group. So this data suggested that if one could predict durable repair based on certain preoperative clinical or echocardiographic factors, there's likely a subset of patients who will derive greater benefit from repair rather than replacement. So this led to multiple studies looking at the valvular and ventricular parameters that could be independent predictors of recurrent MR in the repair group. The high rate of recurrence in this group can be explained by the fact that a one-size-fits-all approach was used in this study for all ischemic MR, regardless of the mechanism. In reality, the mechanism of MR in patients with anterior and posterior MI are drastically different, but they're often grouped together in trials. While an annuloplasty ring alone may decrease MR in patients with anterior MI who have usually symmetric annular dilation, this approach does not directly address the tethering of the posterior leaflet seen in the posterior MI. So persistent posterior leaflet tethering was identified as the main cause of recurrent MR in the patients undergoing repair. And those with basal aneurysms or dyskinesis, which then resulted in severe tethering, were identified to be at high risk for recurrent MR after a repair. And multiple subvalvular procedures such as papillary muscle approximation, relocation, and chordal cutting to decrease that tethering are currently being studied. But we need large-scale trials with patients stratified according to the pathophysiology of MR to identify which patients will benefit from repair versus replacement. So in summary, revascularization benefits patients with ischemic MR when compared to medical therapy alone. However, revascularization alone is associated with high incidence of persistent MR. Mitral valve surgery could be considered for patients with moderate ischemic MR undergoing concurrent Cabbage if they have poor myocardial viability. And since improvement of the ischemic MR is closely related to the functional recovery of the viable myocardium after revascularization, viability studies may provide useful information on improvements in LV dysfunction and ischemic MR. And lastly, Replacement should be considered over repair for those patients who have severe posterior leaflet tethering or basal dyskinesis. So how should we approach ischemic MR? We all need to recognize that ischemic MR is a heterogeneous disease and a very complex disease. I know you're all expecting a great debate here, but the question here is not whether one treatment is better than the other, but instead it's about appropriate patient selection. Optimal medical therapy is the cornerstone in management of ischemic MR. However, we've seen that in patients with persistent MR despite medical therapy, a pathophysiology-guided approach is necessary. We need to take on a multidisciplinary approach and use our imaging modalities to define the etiology, the degree, and the mechanism of MR, and then utilize a heart team approach to identify patients who are eligible for surgery and those who are not. For surgical candidates at low risk for recurrence, a mitral valve repair could be considered, and those with imaging findings of severe posterior leaflet tethering or basal dyskinesis can be considered for repair with subvalvular procedures or replacement. And those patients who are high risk for surgery but fit the COAPT criteria could be considered for MitraClip. And on the far end of the spectrum are patients with end-stage cardiomyopathy who will better benefit from LVAD or transplant evaluation. And should also recognize the role of palliative care for patients who are severely frail and have multiple medical conditions. Thank you. I want to thank Dr. Steve for his assistance and my co-fellows who work with me on this PowerPoint.
Thank you very much, and a terrific job to all of our fellows. We may have time for one question if anybody has any questions. Otherwise, we can wrap things up. But as I mentioned before, feel free to put a question in the chat function or raise your hand and you can be unmuted. All right, well, if there's no questions, I'll congratulate all the fellows and their mentors on a terrific, balanced, insightful presentation, and remind everyone to join us again next week when Dr. V from Cardiac Surgery will be presenting. All right, thank you very much and take care.